Welcome to Africa and COVID-19 Communities. My name is Julie Crowley, and I am the Regional Director for Central and West Africa for IDRC, the International Development Research Center. Today's event is the first of our roundtable series on Africa's COVID-19 response and future pandemic preparedness. And we are delighted and honored that some of Africa's leading minds have responded to our invitation to discuss the role of innovative, health-related, community-based approaches in strengthening Africa's COVID-19 response. Before introducing our moderator and guests, allow me to provide some guidance on the platform. First, translation. You will have already chosen your language of preference when you joined. Please note that you can go back and change this at any time by pressing the language button on your screen. Second, there will be a question and answer period during the event, and you can submit a question or comment at any time. To do so, simply click on the Ask a Question button on the navigation bar of the webcast player, and an application called Slido will open up in a new window. Third, should you experience any technical difficulties, click on the Help button, submit your problem, and you will receive immediate assistance via email to begin troubleshooting your issue. Now, it is my pleasure to introduce our guest. Dr. Mosaka Fala is the President and CEO of Refuge Place International. He was previously Director General of the National Public Health Institute of Liberia, which was founded as part of the response to the 2014 Ebola outbreak. Dr. Fala has a PhD in immunology from the University of Kentucky. Dr. Fala, welcome. Mrs. Caroline Bindio is CEO of AMREF Health and Innovations, AMREF Health Africa, which in response to COVID-19 has been supporting government-led efforts and providing technical support, including helping to increase testing capacity. Mrs. Bindio is an experienced leader in the fields of global health, innovation, technology, and international development. AMREF was previously known as the African Medical and Research Foundation. Mrs. Bindio, welcome. Dr. Sabin Nsanzimana is Director General of the Rwanda Biomedical Center. He has extensive experience in HIV program design, strategic planning, implementation, and operational research with a focus on global care and treatment of people living with HIV. Dr. Nsanzimana is closely involved in the COVID-19 response, including serving as chair of the Scientific Advisory Group for Rwanda. Dr. Nsanzimana, welcome. Professor Jane Byakika-Tusime is an associate professor of epidemiology at Soroti University in Uganda and heads the Department of Public Health. She has 20 years of experience in research and monitoring and evaluation in HIV/AIDS, tuberculosis, and maternal, newborn, and child health. She is currently supporting Uganda's COVID-19 response, and she supported Uganda's response to the 2019 Ebola outbreak. Professor Byakika-Tusime, welcome. Professor Jean-Jacques Muyembe est le directeur.
Professor Jean-Jacques Muyembe is the Director General for the National Institute for Biomedical Research in the Democratic Republic of Congo. He spent the last 40 years working on research on Ebola and now heads DRC's response to Ebola and COVID-19. In 1976, he was the first scientific during the Ebola crisis, and he realized the test from which we were able to isolate the Ebola virus. Welcome.
Jean Lebel, President of IDRC. Without further ado, I would like to hand the discussion over to him. Jean.
Merci, Julie. Thank you very much, and welcome everyone on the web. As Julie mentioned, my name is Jean Lebel. Sometimes I'm also called Jean Lebel, and at this time of the year, Jingle Bell. But that should only put a smile in your face and not distract from this very important topic that we will touch this morning. It is a privilege and an honor to have such a distinguished plateau to discuss and explore Africa's COVID-19 response and its future preparedness or actual pandemic preparedness. You are leading mind to discuss the role of innovative community-based approaches in strengthening Africa's COVID response. And our audience will certainly learn a lot, and please keep your question for the end, dear audience. I will use a few words of French, and it's to situate the work of IDRC in relation to the COVID-19. Alors, en réponse à la COVID-19,
in response to COVID-19, IDRC has worked and is working with partners throughout the world to respond to urgent needs and reinforce capacities locally while focusing on the most vulnerable populations. Our intervention, our response to the pandemic targets both direct impacts of COVID-19 on health and also broader economic and social impacts of the pandemic. As we've always done, we reinforce capacities locally to respond to this pandemic. We are implementing evidence-based guidelines on health workers, by providing specific instructions to manage the flow of patients in hospitals, to control infections, to supervise patients, and to support communities in case COVID-19 is suspected.
When COVID-19 surfaced, global health experts worry that Africa would be particularly hard hit. The WHO warned in May that up to 190,000 people could die across Africa and up to 44 million could be infected in this first year. So far, confirmed cases recently reached 2 million, and confirmed deaths are only now approaching still 50,000 people, according to Africa Centers for Disease Control and Prevention. And the picture across the continent, as you'll see this morning, is quite varied. For instance, South Africa has reported more than 800,000 cases, while Senegal has reported about 16,000 cases. Those are data from October, I believe. There are a few theories, and I say theories, on why the pandemic has not been as severe in many countries in Africa, including that most African countries have COVID-19 under control, that Africa has a generally young population, whereas COVID-19 mortality is generally higher in older population. That initial assumption of great vulnerability and lack of capacity were faulty, especially given that several African countries had increased their disease response capacity following various outbreaks in their history, such as the 2014 Ebola and the more recent episode in DRC. Some say that given the generally low level of COVID-19 testing per capita, it is possible that cases are being missed and the data do not reflect what is really going on. And that also COVID-19 will go on a slow burn that ultimately causes similar levels of morbidity to other regions. No doubt the situation is complex and that, many are looking for answer to this. And today, our objective is to have this dialogue with you, but taking a particular angle about collectivity and COVID-19. And why are we talking about community collectivity? It's because, during the previous epidemic of Ebola in West Africa, for example, in 2014, we learned quite extensively that the participation of community in the adoption of intervention are quite essential for stopping the spreading of the disease. Today, we'll seek to accomplish two things. identify community-based responses and discuss lessons learned from this pandemic and previous disease outbreaks, and identify gaps in opportunity for strengthening community-based disease outbreak preparedness and response. And for this, we have with us researchers that are from the field, that are active in the field, and that speak in spade of the experience they have with community-based interventions. We will have perspective from Liberia, Kenya, Rwanda, Uganda, and Democratic Republic of Congo. And we will learn from COVID in each of these landscapes, but also from their past experience, as well as what is currently taking place in their own jurisdiction with the COVID-19 response. So without further ado, I'll start my interaction with you, dear panelists. First of all, welcome today to you. Thank you for being with us and having offered so generously to participate in this first series where, as we say at IDRC, we help to build a platform. You are delivering the keynotes. So today, we want to hear from the field, from the reality of the ground, what is going on and what is your perspective on these community-based intervention. And I'll start with the same question to each of you. And I'll start with Musoka Fala from Liberia. And Musoka, give us in a snapshot, what is the situation of COVID-19 currently in Liberia?
Thank you very much. So as of the 10th of December, this is the current state rate. Just before I proceed, to just dovetail on the key points you raised. In the last couple of weeks, we have seen a surge in the number of cases of COVID in Liberia. But what is interesting is that these cases have been discovered among travelers. One of the requirements for travelers leaving the country is you get tested. So the question is, could this be the tip of the iceberg? Because these are random people who are asymptomatic. They are ready to travel and then they go for the test and they discover that they are positive. And so we are seeing increasing number of cases among people who are ordinarily okay and about to travel. And so as of the 10th of December, for instance, we had 13 new cases, and most of them among travelers. Most of these new cases are concentrated in the capital city, Montserrat County, that has around 1.3 million of the 5 million Liberians we have. So now, as of the update, all the time since we confirmed our first case in March 16, we have had a total of 1,676 cases. Active confirmed cases in the recent weeks, we've been a total of 235 cases have been confirmed of late. Like I said to you, as of the 10th of December, we had 13 cases. We have had 83 deaths, which gave us a case fatality rate of about 4.99, meaning to say Liberia has the highest case fatality rate in the ECOWAS region. We have the highest with 4.99 out of the 1,606 of 83 deaths. The good news is that we have had 1,358 recovery. There has been 1,558 recoveries. Massive testing have been done, but up to now we've done about 35,900 tests, laboratory tests. Just as of the 10th, we had 330 new samples tested. So that's basically where we stand. Like I said, we've had 83 deaths. These deaths, the bulk of these deaths happen in the health facilities. 43 of the 83 deaths happen in health facilities, 13 in the treatment unit, and about 27 in the communities. So this is where we stand as of the 10th of December. Surge in new cases. Yeah, go ahead.
And very rapidly, Musoka, in your opinion, is it going in the right direction or in the direction where we are starting to see only the tip of the iceberg very shortly?
Yeah, so surely, I think we've seen the tip of the iceberg. What that simply means is that we only seeing people that have coming and presenting themselves because they want to travel. And so that's one. So there are two major concerns we have. One is that it could be the tip of the iceberg because we are discovering this among travelers. The second issue is that contact tracing has actually broken down. Right now, we're doing one case to one contact. As of yet the third, we have 96 contacts on a follow-up. So contact tracing has broken down, and people who are healthy. But that adds to the major complexity of Liberia or Africa. My colleague who is at the lab is saying that most of those that they are discovering among the healthy traveler have very low CT values, which means they have a high viral load, but they are walking around very healthy. So that becomes the complexity. Thank you.
Yes, the asymptomatic case. Now we'll move to Caroline. Is she with us? Caroline Bindio? Or yes, she is there. Caroline, what's the situation in Kenya at MRF? What do you see from the field? Caroline, you have to put your camera and your microphone on, please.
I guess multitasking. So hello, everyone. I think like in much of Africa, we are also seeing a surge in Kenya with increasing cases, positive cases. In the past 7 days, we have 5,000 new positives, which is quite significant compared to where we're coming from. In total, as a country, we just have over 88,000 positives to date, and just about 1,500 deaths since the beginning of the pandemic in March of this year.
And Caroline, is it accelerating or is it at the plateau level? What is the trend?
We are on our second surge. Yeah, so we had a surge earlier on this year. We closed down the country. We got the positive cases under control. There was limited community spread, and then we opened up the country again, and we are seeing a surge. So we are seeing quite a significant increase in number of tests done, number of positive cases. We still have about 8 out of 10 of the people who are tested are asymptomatic or have very mild symptoms. So they are receiving home-based care. But of the people who are in hospitals, we are finding that our bed capacity is close to maxed out already. So we are experiencing quite a surge.
Thank you very much, Caroline. Sabin, I saw you knocking in from Rwanda with the asymptomatic case. What is the situation as you see at the Rwanda Biomedical Center?
Thank you very much, and it's a pleasure to join everyone to this great panel this evening, this morning, depending on where you are. But the thing is, as my colleagues just mentioned, we've seen different situations with cases going up and coming down, but depending on also on the movements of people. So like my colleague in Liberia, the first cases in Rwanda also detected in March. But right after a couple of weeks, we went into total lockdown for about 40 days. But when we started to reopen activities with putting in place different measures, public health and non-public health, but now most of the activities are reopened. Slight increase of cases. And because the cases are not showing symptoms, for our case, it is about 70% of people we test with COVID do not show any symptom, unless you do contact tracing. So it's not different from what is described in Kenya, for example. And the thing is, as people also get into these kind of end-of-year holidays and the gatherings and social events, we are preparing also to probably experience an increase of cases, and that's why our communication strategies are going strongly into December, Christmas time should not be like another wave of cases, COVID-19.
So as previously expressed by your colleagues, there's a real concern now with movement within the country and across the border that there might be, some condition that will lead to further increase. Thank you very much, Sabin. Jane Tusime, you're in Uganda. Tell us a little bit, Jane, what is the situation from your perspective? You're an epidemiologist at Soroti University, so tell us the situation in a few lines, please.
Just like other countries I've mentioned, Uganda is also experiencing a surge at the moment as we speak. In the last couple of weeks, we've seen a great rise, an exponential rise in the number of cases. Right now, as we speak, we're about to hit 23,000 cases cumulatively, right from the 21st of March when we had our first case. And together, we've had a total of 207 deaths. Which brings our case fatality ratio to about 1%. What we've also noticed in this pandemic is the number of health worker infections that are happening. As of now, we have slightly over 1,500 infections among the health workers, and we've lost 13 deaths. So as I've mentioned that in the previous weeks, we've been having a surge in numbers. For example, in this week, which has just passed, we had over 2,300 cases that were registered, and with 5 deaths and several, I think 131 health workers that were infected. And as has been mentioned by other people from other countries, we also see that the majority of our cases, about 80%, are asymptomatic. And now Uganda has also started implementing home-based care. So they admit the severe and acute cases in the hospitals, but even in our case, the bed occupancy in the hospitals has also been maxed. We actually had to open one of the football grounds, the Nambole football soccer stadium, to act as a health facility because all the hospitals were full. And right now, I think what we're seeing is actually a tip of the iceberg, just like what Liberia was saying, because in Uganda, the government has come up with a policy of testing only the symptomatic cases because of the limitation or the shortage of testing kits. So it's only those ones who show symptoms. And remember, they're covering only 20% of the population of cases that are tested, which means that the majority of our cases are out in the community and are not being reached. And also we have a challenge of enough funding to support the response. So contact tracing is not happening as it should be happening. So right now, I think we're following about only less than 10% of the contacts that we should be following. And these are the contacts of only the symptomatic cases. But remember also, these asymptomatic have their contacts. So this is really just a tip of...
I'm fascinated. Thank you, Jane. And I'm fascinated this morning by, the similarity in between the situation that you are experiencing, but also the situation worldwide. And the fact that, many of the conditions that you are describing are conditions that we're seeing in other places. And, is this a lag, or is this, something else will need to get investigated in the future? I'll move now to Professor Jean-Jacques Muyembe.
So now I'm going to go to Professor Jean-Jacques Muyembe, who is the director of the National Biomedical National Research Institute in the Democratic Republic of Congo. Professor, it's a great pleasure to have you with us this morning. Are you based in Kinshasa? Professor, are you in Kinshasa? Yes, I am in Kinshasa, yes, for the time being. So try to tell us what is happening in DRC in terms of the COVID. Well, the situation concerning the COVID-19 is very worrying for us, because we had encountered the first wave. The first case was identified on March 10th, 2020. And the epidemic start through travelers. So it was travelers coming from Europe who are starting to bring the virus in DRC, and they have transmitted progressively also the virus to their relatives. And so progressively the spread, the local spread started, and now we have had two parallel epidemics, one that is through import and another one which is an indigenous outbreak. And we reached really the highest point in July and August, and then we set up all kinds of systems to fight against that based on the experience we had with the Ebola virus, to identify cases and to isolate them once they've been confirmed in the labs, and then of course put people under treatment. And at the beginning the mortality rate was 11.9%, but through the improvement of the various measures, then we went to a 2.7% or 17%, 2.17%. So it's a major progress. And the number of cases also has gone down. At the total, we have 13,751 cases. And we have 12,075 that have been healed, and then the difference is the number of deaths. So we really have, we were confident. We thought that we had, the control of the epidemic. There had been altogether 344 deaths. So at the beginning of November, what happened is that we saw new cases again that were adding up. And the various hospitals that had been empty, that had no COVID-19 cases, and started to fill with COVID-19 cases. And we are really right now at the core of the second wave. And I've sent to you the presentation, the slides. Yes, we have, so we can maybe show the slides. So here you see on this slide, the third ones. I cannot see the slides, but you can see on the curve the increase of cases, and it goes up exponentially. And so therefore, this really corresponds to the second wave. And we have strengthened our communication policies. It's important to communicate. And we have one unit, one department that is concentrating on communicating, and based on the experience we have with Ebola, we want to make sure that within the communities there is a clear awareness of what is going on. And we also have a team who is in charge of protecting or preventing infections, especially among the staff in the hospitals or the medical professionals. So this is going on right now. We are going to strengthen as well the epidemiologic monitoring. And the other important element is the monitoring also of travelers. Travelers who are leaving DRC have to go through a test at least 48 hours before taking off. And we also require that travelers that come back from abroad, even if they had a test abroad, when they arrive in Kinshasa, they have also to take a test, which is called COVID-19 travel test. And we have already identified a number of cases, and, they had also positive tests when they arrive in the Democratic Republic of Congo. Thank you, Professor Munyabe. When we go, we'll ask you more questions about the various interventions, what you have been doing, because DRC, until recently, was also facing an Ebola outbreak, and your experience also has brought you a lot of expertise. So thank you very much.
Introduction. Let's go into the substance of our conversation. I'm running already a little bit late, so I don't want to pressure you, not at all, but I want to make sure that we have questions from the audience. So if you could, respond, crisply and sharply to the next round of question, I would appreciate, and our audience would appreciate also. And I'll go back to Musoka Fala. Musoka, in the 2014 Ebola, Liberia was hit hard. It has recovered partially. It remains a fragile environment for the health services, I believe. But, you had a very broad experience with community-based initiative, and how the lesson you learned from the Ebola outbreak are applied currently in the pandemics of COVID-19 in Liberia, and what does it give? Musoka? Musoka, can you hear me? It seems that we lost the audio with Musoka. So, in the true spirit of being adaptive, I'll go to Caroline in Kenya, and I'll come back to Musoka afterward. Essentially the same thing, Caroline, from AMREF perspective. You have been working extensively, in urban settling. Often in urban settling, you have not only the diseases that are present, but you have also some, poor condition related to, the absence of the basic social amenities or physical amenities. So what is the experience of AMREF with these community-based intervention, and what are they delivering right now with COVID-19?
Mm-hmm. I would say that, at AMREF, and I would say with many countries in Africa and in Kenya, we have robust community health worker systems. And these systems are used to provide services door to door, on a regular basis, looking at things like maternal health, child health, water and sanitation, nutrition, the usual services that are provided at primary health level. With COVID-19, it became absolutely clear the value of these community health workers, where there was a restricted movement, where the virus itself is novel, therefore not much information was known about it, and using ways and means of building the capacity and training these community health workers so that they can go door to door. And what we saw is the value of having that network in place before you need it, the value of using community health workers who are trusted within their communities to spread the information and to really get households to begin to understand how the response is. Many of these community health workers live in the communities where they practice. So they understand their community well, they know their cultural norms, they understand the people who they are working with, and can be able to even bring feedback to say, in my community, this is what we see. How can we message appropriately so that we can get to the behavior that we are seeking? This is the problems that we are having. These are the bottlenecks towards adherence with some of the guidelines that are being given. What can we do? So having that network of community health workers who are in place and who can then be leveraged to provide these services was absolutely critical.
Yes, and this must be quite demanding on your community health worker because, there's a limit there. So are they strained? Are they exposed? Is there a problem of numbers over here in terms of basic human power, human arms to deliver the work?
Yeah, absolutely. I mean, because what we're saying, even without COVID, the community health workers have a significant workload. Many of them are volunteers, so they don't get, a pay for the work that they do. Many of them, have families that they need to be feeding, children that they need to be taking to school. And then with COVID, there's this new additional work that they do. So even as we speak about COVID, we also look at how do we not just message COVID to households, but also talk about the essential services that children should continue to get immunization. people with chronic illnesses should continue taking their medication. So these community health workers, this is the work that they do. Many times they put themselves at risk because they don't have PPEs and protective equipment, protective gear. The households themselves may not even have that as well. So even if they are washing their hands, they have a mask on, many of the households where they are going, perhaps that is not even available in those households. So it is a risk. It is stressful. We are seeing, cases where community health workers are needing support, and the households that they're serving are needing psychosocial support to help them to just get through this pandemic.
Thank you very much. Let's move to Sabin. Sabin, in Rwanda, you were quite innovative in having pool testing strategy as part of the national pandemic response measure. And give us a few words about what is this innovation and what was the role of community-based approaches in order to integrate this into your country pandemic response?
Great, thank you. So one of the biggest challenges we had as a country in the beginning of this pandemic was to be able to do diagnostics and all the tests that are required every day. So I remember the first week of this kind of pandemic start in March this year. We were testing about 200 samples a day. And that time, the demand was quite high, in thousands. Everyone wants to do a test. Contact tracing was quite high, and we couldn't manage. So at the same time, we were developing our diagnostic capacity. By bringing in new machines, the supply chain wasn't so easy. And also lab technicians to run these PCR tests were not something you would teach in a week time in a crisis mode. So we had to find different solutions. So we tried this pool testing, which is basically in the principle is not something really new. It has been done for other diseases in the past, but we tried it in our laboratory, and we want to see if by mixing different samples, we started with 20 samples. Within one tube, and you run one tube as a sample, but the tube represents the result of 20 people. So our plate, which runs about 96 samples, would be running 96 multiplied by 20, which means you have more people in one run. So we tried it several weeks, and then we had conclusive result. So for every negative tube, all the 20 people sample, and whenever there is a positive in one sample, you had to test one by one. We were lucky that time, the beginning of this pandemic management, because the prevalence was still very low, and the chance to have more negative tests were really high. So when we started to see an increase of cases in June, we adapted this pool testing to 10 samples in one pool instead of 20. And we are still doing this pool testing for places where we see very low prevalence. And we use usual techniques for higher prevalence settings if we suspect mass transmissions.
Are you aware?
On the second question,
but Sabin, before we get to the second question rapidly, are you aware of other countries using similar approach for testing, pool testing?
So I know that some countries have been interested to do the pool testing. I've been reading about some colleagues trying this into their context, including I think United States. We've worked with colleagues at CDC who I think have also started a couple of months ago. But I think this is one of the best way to test more samples in a short timeline. And I wanted to highlight that with this pool testing, we moved from 200 samples a day to 10,000 samples a day, which is our current capacity. And we've been doing these tests every day. Our labs also about 12 hours in terms of coverage, but still pool testing is.
Thanks, Sabin, for Sabin for this. Jane, I'm moving rapidly to you because in Uganda, you launched a community engagement and social protection strategy for COVID-19 at the level of the country. And what do you see in this strategy that links it to the community, and how do you plan to scale this strategy out in the country?
Sorry, I was muted. In Uganda, we have a lot of experience in preparedness and emergency response in the control of infectious disease outbreaks for over decades, and other countries have actually been learning from us. And so we're using this experience in HIV, Ebola, bird flu, SARS, and others to really also run this epidemic. And in Uganda, for example, HIV led to the establishment of a multi-sector Uganda AIDS Commission. Then with Ebola, it led to the establishment of the National Outbreak Task Force, and then a command center and decentralized surveillance and strengthened laboratory capacity across the country. So we want to build onto this experience that we've been using over the other pandemics. So the Prime Minister of Uganda recently launched the National Community Engagement Strategy for COVID-19 developed by multi-sectoral committee. So there are several different sectors that are actually the Ministry of Internal Affairs, the Ministry of Local Governments, and so many others are involved. And the overall goal is that all people in Uganda are aware, empowered, and are participating in the prevention and control as both a duty and a right, using existing structures, systems, and resources as much as possible. So this strategy is underpinned by the principle that individuals have the primary responsibility for maintaining their own health and that of their families and communities. So they will be supported where necessary by skills and knowledge and technology of the other professionals. And this community engagement strategy will strengthen the existing community health systems for integrated people-centered primary health care as the national COVID-19 response translates into phase 4. Right now in Uganda, we are in phase 4, just like other countries are, with widespread community transmission. And this strategy will ensure that infections do not occur in the community, and if they do, they'll be promptly dealt with to identify, test, treat, and do rehabilitation. Now, as I've mentioned, there is inter-sector collaboration with this strategy using the whole of society approach, which have been recognized as the most effective interventions for achieving the SDGs and universal health care coverage and pandemic control. So Uganda will have we hope that Uganda will have a strong integrated people-centered primary healthcare system for the current COVID-19 response and beyond as the first line of defense against infectious diseases.
So the pandemic is playing as an accelerator for, some adjustment to the health system that were probably long due. Isn't that case?
Absolutely. Yeah, you're correct.
Yeah. Good.
Yeah.
Thank you, Jane, for this. I have Mosuka that I think is back. Mosuka Fala from Liberia. Are you with us, Mosuka? I see your hand up. You are indeed. Yes. I hear you. So, Mosuka, I was asking you earlier, having gone through the hardship of the Ebola in 2014 in Liberia and having suffered extensively with the health system that has been highly affected, what has been the learning in terms of this outbreak in 2014 and its application of the learning to the COVID situation, particularly with the engagement of communities?
Thank you very much. our experience from the Ebola was extreme. We had resistance, military intervention, people died. And so one of the things we tried to do was engage the community ahead of time. So as late as in late January and early February, we started the preparedness for the COVID-19. We initiated enhanced airport screening, did an assessment of the laboratory, sent a team to Senegal, to the Pasteur Institute, to get training, and brought a team back, and then set up the testing. So we're long prepared because of the legacy of Ebola. We got prepared to do the testing, and then we started with massive community engagement. We invited all of the superintendents, the religious leaders, both the Muslim and the Christians, and started doing extensive community engagement. Another thing that we saw happening was because of our work with Ebola on the network of communities, I was able to visit a couple of communities, and on their own, spontaneously, decided to do awareness and started to do hand washing. I was so moved when I went to 3 of the biggest slums to visit, and those people took off their Ebola t-shirt we had made for them, organized their structure along the line, set up hand washing bucket, set up some innovation where they could not get bucket, get empty gallons and open the side of the gallon to wash hand, enforce hand washing. So those lessons from Ebola in terms of mobilizing the community ahead of time, utilizing the existing network and structure that were created from the Ebola, and the overall preparedness in terms of laboratory and public health. Liberia was one of the first countries to start doing the advisory and the airport regulation, enhanced screening. All of these were a consequence of the Ebola. Yeah, our lower cases, sometimes people can allude to those facts. And so also the community saw themselves, instead of resistance that we saw with Ebola, was that they were on board. They joined us, decided their own innovations, even before government could get involved. So those are some of the key lessons that we gathered from the Ebola.
Thank you very much, Musoka. And I'm sorry you don't have the video, but we can hear you perfectly well. Professeur Muyambe, je me tourne vers vous.
Professor Muyambe, I'm turning to you now. You have had a lifetime experience on managing Ebola in Western Africa. Recently, you faced another Ebola epidemic that occurred in a very difficult social context. Please tell us about why community engagement is so important, but tell us also about the risks involved sometimes, as we saw with the last Ebola crisis. And please tell us how these lessons can be helpful in managing the COVID-19 pandemic in DRC and elsewhere in the world. Thank you very much. For us, community engagement is the basis, the very basis of our fight against all these epidemics, for which we have neither medication nor vaccination. From the outset, we used what we call here community relays. These are people, volunteers in the communities who are interested in health issues and who are the connection between the community and health institutions. So these are what we call the community relays. So these people go into the villages, into the communities, the connection has stopped. Professor Muyambe says the moderator, we have lost you. Have we lost Professor Muyambe? I believe we've lost Professor Muyambe.
We will come back. He will get reconnected. So let's continue as he will come back. Vous êtes là, professeur? Alors
You're back, Professor. We lost you for a few moments. You were talking about all the work done in the communities by community relays. Yes, we're having a connection problem, but I'm back. So I was saying that community engagement is the very foundation of our fight against epidemics and against disease for which we have no vaccines and no medication. Our experience is based on the use of community relays, who are people working on a voluntary basis, who are the connections between the communities and health institutions. During the epidemic, we also used a special commission which is responsible for communication and community engagement. The members of that commission, including reporters and communication specialists, are people who go into communities to do awareness building, to reduce the risks of resistance, and to promote their involvement in the actions taken by the government. And so community engagement is really the essential component of all this. It always has been the essential element in our fight against the Ebola epidemic. And with COVID, we are using basically the same strategy. And it is fruitful. We think that it's an experience that we can share with the entire world to manage these diseases, which are community diseases. Thank you very much, Professor Muyembe. I would like to stay with you and say this. We have a concern here. We're talking about vaccination and developing a vaccine. And the concern here is, will we have enough doses? Is it safe? You're aware of all the discussions. But at IDRC, the real question also is, in your country, what is the conversation around the vaccine? Are there expectations? Is there anxiety? And how will community work be used or needed to find a partial vaccination solution? Let's say partial because it's only one tool in the toolbox. Please give us your opinion on this, since access and availability of the vaccine for the African continent is an issue that is predominant, that is front of mind for us at IDRC. Yes, when I see France, I realize that there's a lot of questions with regard to these vaccines. People are leery of it, and in Africa, even more so. This mistrust about the vaccine. And so the work of the government is to convey a clear message, to build awareness within the population so that it accepts the vaccination. Our European friends, our Western friends are not making things easy for us. In the Western world, there always are ill-intentioned individuals who speak negatively about these vaccines. And when we hear those discussions in Africa, they get amplified. And African citizens are afraid. They think that young women will become sterilized, infertile here in Africa, or some bugs will be in the vaccine, etc., etc. So the bad press this vaccine is getting is very bad. And I'm afraid it's going to be a failure here in Africa, and in particular in the Democratic Republic of Congo. So definitely here, research can play a key role to inform deciders and to inform the citizens through this network of community relays. Yes, absolutely. That's the biggest part of the work that we need to do. Promote community engagement and promote awareness within the citizens. Beyond that, as far as technology is concerned, we're used to using these vaccines that need to be conserved at -70 or -80 degrees. We did that with Ebola. It worked well. We have the logistical capacity. The biggest problem here is going to be citizens' acceptance of the vaccine, reducing the citizens' resistance to it. Thank you very much, Professor.
Question I've asked Dr. Muyembe, which is, in our countries, in Western country, there's this hip about the vaccine, which is quite important and required and needed. But at IDRC, and a lot in the population, this questioning about access, distribution, availability of the vaccine worldwide, and particularly on the African continent. And how does this jive with the conversation you see? Professor Muyembe was saying that there's, still a lot of skepticism in the population. And when news comes about vaccine safety, effectiveness, negatively, it's amplified when it reaches the ground. And it's essential for government, to prepare well and to have the community health worker to be well informed in order to carry the truth vis-a-vis vaccination, which is one part of the solution, not the entire part of the solution. So, Caroline, what's your perspective on the vaccine and on the community engagement, please?
Yeah, I would say this is a critical question, and it's something that we are discussing in Kenya right now. And what does COVAX mean for Africa and for Kenya? Even without, thinking of COVID, there is vaccine hesitancy in Kenya and in Africa, generally speaking. The vaccine systems that we have are geared towards child immunization. Thinking about the vaccines that are currently, in advanced stages, and the delivery of those, the logistics involved, if you're talking about cold chain and how that would look, the vaccine is only as good as the distribution channel within the countries that are going to distribute this to the population. So I think there is debate around when will the vaccine reach Africa. Will it be a people's vaccine? Will it be at cost? Will people be able to afford it? Will governments be able to afford it? If even assuming that all things go well, the government brings it into the country, will people accept the vaccine? So there are really a lot of questions that are being asked and a lot of work which is already being done to try and prepare both the country, the health system, the population itself, to ensure that as the vaccines get here as soon as they can, that the distribution channels are ready, that there are systems to ensure that there are protocols, first of all, to define who are the priority people to be vaccinated, and then how it reaches the rest of the population, and that there is enough information within the public so that people make the choice to accept this vaccine.
Thank you very much, Caroline. Sabin, in Rwanda, do you feel this lag or this misinformation gap, that is present vis-a-vis vaccine?
Yeah, we start to hear voices. In the beginning, when there was no hope for vaccine, everyone was talking about when are we getting the vaccine? So now that we're getting closer to a vaccine, there's people are saying, do I need it, or we should wait a little bit? But this is like a group of people. It's not the people we are talking about who need to vaccinate urgently. These people are high-risk groups, elders, people with other comorbidities. These people who are in front line, like doctors, nurses, who are always managing patients who may be at risk of these diseases without even showing any symptom. But I have seen this for almost all vaccines we introduced in Rwanda. We've seen it for Ebola. Professor Muyembe was talking about it. This is a vaccination at the border between Rwanda and DRC. And we're about to finish vaccinating about 200,000 people crossing border between Rwanda and Democratic Republic of Congo. So to me, this kind of discussions or questions about a new vaccine have existed before, and we understand how it's magnified now because of COVID is a pandemic. It's not something we've seen before in 100 years. But I will see that people will be more and more open to take the vaccine or discuss about it as we see the first phases and the first people are protected. So I don't, personally, I'm not worried about this issue because it will change with time and it will change with the science showing us different vaccine candidates have actually brought to with benefits, protective than harms, as many people may think.
Sabin, if you're not worried about this issue, what is worrying you right now vis-a-vis the pandemic we're facing in the Rwandan context?
My major worry now is the fatigue that some people have traditional public health measures like wearing masks, washing hands, keeping distance, particularly in Africa, in our communities, when people are used to be together, to hug each other and to live in a community. And now we are telling them, no, stay away from each other. So they managed so far, at least to what we told them to do in our context. But if we stay longer and longer into these situations, it will reach a time where communities will say, oh, we're tired of these strict measures. So that's why I think we need to have quick solutions. Exactly. So, and the last one to me is vaccine is not going to replace all these measures in just a couple of months. So we are going to stay probably one more year with the vaccine and plus other measures that people are tired of following. So you see the complexity of 2021. There's a hope, but yet there's no hope yet.
Yeah, absolutely. Very savvy words over here, Sabin. Let's move to Jane, and we'll close with Masuka. Jane, you know, the vaccine, the community intervention, what's your perspective here?
In Uganda, yes, of course, the government is already discussing about the vaccine, and they've already started developing a vaccine deployment plan. But when you get out to the community, you don't feel that anxiety that people are anxious about the vaccine. What they're always going to ask is, when is the vaccine coming? What kind of vaccine is coming in? But you don't hear questions of, you know, being concerned about the safety of the vaccine. To me, it's like people are ready to receive this vaccine. So I wouldn't really be so much worried. And we hope that actually, as we start on the vaccine deployment plan, the risk communication team is also working very hard to let the people know that the vaccine is there. But because the question that comes often is, when is the vaccine coming? When is the vaccine coming? So we tell them that maybe in 6 months or even a year. It's not about to come now. So what we have to really stress are these other interventions that we've always, you know, talked about, washing hands and, you know, keeping distance, because everybody seems to be eager. Now that they've been hearing about the vaccine out there, it's like they think, even in Uganda, we're going to get it in the next few weeks or months, but they have to be told that, you know, hold on. You have to maintain all the other measures. Otherwise, we're not worried about people being very skeptical about the vaccine.
Okay, well, thanks for this. And Masuka, you're the last one to come on the vaccine and community intervention, please.
Yeah, just like my colleague said from my last colleague, Liberia, we've done well with vaccine. The reason being that we're one of the first countries that pioneered the Ebola vaccine. There was a lot of steep claim to accept the Ebola vaccine. We did most of the tough jobs. In fact, I accompanied the first team that went from CDC and NIH to do the community perception. It was a long, steep battle, but we overcame that. And we're able to test the first phase 2 trial of the Ebola vaccine that was used in the DRC. And we also used the vaccine as a normal response, the Ebola vaccine. In the three resurgences of Ebola, we use vaccine as a normal response. So just like my colleague said, the acceptance towards vaccine is very high as a normal part of a response in Liberia, based on the tough experience we had to first accept the Ebola vaccine. Once we established the fact that we're able to do Ebola vaccine successfully in Liberia, vaccinated over 1,600 persons, eventually vaccinated for response, it is accepted. What is worrying me is on the supply side. You know, that Professor Muyombe has said on the Merck vaccine. One of the issues that is coming up, for example, is the issue that the manufacturers are putting patent. And with the patent, the vaccine are not going to come to Africa very soon. That's one thing that really bothers me. It really throws me off that this should be a public health good, but people are trying to make money out of it. How is North going to do something about that? And then the distribution and the coaching, -80 I was just listening to Tony Fauci. How are we going to overcome the logistics of moving vaccines that are needed to be at -80 and the fact the pharma company are demanding billions of dollars, they're refusing to let the patent to go. That frustrates me so much. I was just telling my colleagues when I could read an article for Africa CDC, they should be a public good. I mean, these are issues we want to resolve from the supply side. But for us in our country, it's not an issue. How do we take care of the supply side for equity and fairness in the world in which we live?
But did you see movement at the African CDC towards enhancing this?
Yes, I read an article, Africa CDC and a few other countries are advocating that we should remove or suspend the patent for the vaccine for the time being. You know, there's going to be a big advocacy that needs to happen from powerful nations. I feel it's so unfair. I mean, I said part of the Ebola vaccine group. Even under the Ebola vaccine, after Licensure, Africa is going to be the least. I've advocated for this. Professor Muyombe was with me in Senegal when I felt that most of the tests for the Ebola vaccine was done on African. Now, post-Licensure, Africa will not get preference. And so the same is going to happen now with COVID vaccine.
Thanks for this. Listen, participant out in the cybersphere, you have the opportunity to ask question. It's in the upper right button, I think, of your image that you can have a little punch there and enter your question. We already have received a few. I'm going to ask them to you in no specific order. Feel free to jump if you want to answer, dear panelists. But, you know, this is rapid firing because I see time running by and I want to use a maximum of time for question. So there's a question about, you know, the challenge that there is in population vis-a-vis, you know, the economy and how people are suffering from the pandemic because of lockdown, because of increase in prices. And how does this, you know, get resolved or looked at in your country? Is there a stimulus package present? Is this sufficient? Do you see, in other words, a lot of suffering that is not caused necessarily by the health situation, but by the economic situation that comes with the pandemic? So any one of you just comes in and will dispatch. So Sabeh, I see you, you know, wanted to come in, please.
Sure. But I think there's a clear connection between health and all sectors of the lives of a country or our communities. So what we've seen with COVID, and I always see that we will not see the health sectors similar ways we've seen it before, because what affects the health of a nation or a health system immediately affects the economy, affects agriculture and the other sectors. So what is happening now, we are more and more into recovery phase from a real challenge that every single sector has faced, communities, people, small jobs, and even the health sector itself has been shaken severely by managing this pandemic and existing diseases and pandemics, including HIV, TB, malaria in our context, which is still a big challenge. So when you look at it, and it will take some more years to go back to where we were before COVID-19. And what is being done currently, to accelerate this catch-up into the economy, into other sectors, it is not enough in many contexts because the pandemic is still there. We still invest into diagnostics, into contact tracing, into management of patients, into telling people, please don't open the economy too much because then you have too much diseases, too much viruses. So this balance between the virus management and keeping business and lives at the level, acceptable level, it is something that is going to last probably a little more time, and it is not going to boost the economy back so quickly. So we need a lot of stimulus. We need more of supporting economies that are severely affected and to the level of communities and individuals and try to help those who have been severely affected, those who can't even afford some food because of COVID-19.
Yes, and you're making me think about, we have sponsored a number of think tanks to think about and provide advice or answer questions from national authority vis-a-vis the reconstruction following COVID. And some of the first results that I saw from ODI in the UK working in various jurisdictions is that stimulus package in the country of the G20 is on average $3,200 per head count. In LMIC, it's $52. So, you already saw this inequality, in a response measure related to the capacity of countries. And I think that you're putting your finger right on something. You have to manage the two, and sometimes in a far more difficult situation than more developed economies. Thank you very much. Other wants to come on this question of, the stimulus package and the economic impacts of the pandemics. Caroline?
Yeah, I think we see a lot of the same in Kenya, where I think it's estimated between 500 and 700,000 households have moved into the poverty category. We have seen a lot of businesses closing down, especially small and medium-sized businesses. We have seen individuals who are day wage earners now no longer being able to, have a way of having any income of any kind. The government has had several kind of packages to try and cushion the citizen, things like, people who have personal income tax, having some rebates around that, as well as corporate income tax. But that is also only looking at people who are already earning, a wage. A monthly wage. For those who don't, there are packages around trying to see how they can get health covers for households who are within, the poor category, the indigent category, so that they can be able to access health services and not become further impoverished, even without COVID, because of other things that are happening in the health of those households. We have seen the education sector for us in Kenya, which has been closed for most of this year. The school year was essentially cancelled and is going to be restarting in January. So we have a lot of students who, have fallen into teenage pregnancy and, other things due to having no school to go to. We have children who are, being fed in school, who are not going to school anymore, therefore they're going hungry. So there are a lot of other repercussions of COVID-19 outside of the illness itself that we will be dealing with in 2021 and in the years to come that are going to hit the country hard.
Thank you, Caroline. Professor Muyembe, les femmes.
Professor Muyembe, what about women? Do women receive a fair treatment, an appropriate treatment, whether they're a victim of the pandemic or since they are also the majority of health professionals, especially in communities? Well, in our country, women are also the victim of the COVID, as of course men, but since COVID-19, how can I say that? It really challenges, the how we can provide basic services such as, childbirth and vaccination of children. So all the system is, of course, disturbed because of the COVID-19. And women in our country usually have small, the small businesses, small stores, and they are, of course, also a challenge because of COVID. So women have lost a lot in terms of the economic activity as well during this pandemic. And, in Africa, women are the ones who actually feed the family, because husbands have no work, and actually it is women who sell their produce and on markets and everything. And when this is not possible anymore, well, then of course households suffer a lot, and women in particular. Thank you, Jean-Jacques.
We have one question related to the community health worker that, many of you have mentioned are often volunteer. And given all the importance we put on this, why are they volunteer? Why don't they get, some salary to perform their work if they are so important?
Sorry, I was struggling to get my mic on. Just repeat the question quickly again, please.
Yeah, Jane, if the community health worker are so important, all panelists has pointed to this, and many are volunteer. How come we don't pay more attention to providing them with a salary rather than having them as volunteer?
That's a good question. And actually, it has been realized of late that these people put in a lot of their time. They also have families like anybody else, and they spend a lot of time to do this community work, and they need to be, they need to be compensated for their time. So that's why in this new community engagement strategy that Uganda is starting, they are considering to start paying the community health worker, which has never been there before. Previously, they were just giving them a little stipend, maybe to motivate them, but now the government is considering paying them a salary. The only snag to it is that the health workers are so many, and it will require a lot of funding from government. So they're just going to start little by little. But at least we are in the right direction in that they're going to start paying them. Right now, the proposal is to pay for one community health worker per village, but a village can have, close to 10. But now they have to pick out one, which is a challenge, but at least it's a step in the right direction, because they realize that if this person is going to put in all this time, they need to be compensated for their work.
Thank you very much. Masuka, I see your hands up, and I'm going to give you the floor for in 30 seconds. If you had the magic stick, in order to do something that you think needs to be done urgently and now in Africa, in Liberia, what would be the stick used for? One thing in 30 seconds. And unmute yourself.
I think, yes, an extensive investment in community engagement, empowering communities because now we realize 60 to 80% of the cases are asymptomatic. They will have to be managed at home in the communities. The traditional practice of wearing masks and hand washing, all of these can be driven by the community. So I think an investment in empowering of community with the appropriate information, the appropriate resources, like my colleague spoke about the hardship they are going through, some form of incentive. We saw this happen with Ebola when we repurposed the Ebola economy. Initially, the Ebola economy was only for the international expert, but we took the money, we convinced WHO and UNDP to put the money in the hands of the communities. We're able to raise $4 million and put that in the hands of the community and made a difference. So some of the high impact resources, if we can put them together in the appropriate tools, appropriate marks, messages, and help them meet their basics of our needs, I think we'll make a big difference. That's just my thought. Empowering them with the right message, the right tools. Yeah. Thank you.
Thank you very much, Masoka. Jane, 15 seconds. The magic stick. What do you do?
For me, I would really love to see more people in the country tested. If we could get enough testing kits in the country, then we would know the actual magnitude of the problem in Uganda. Right now, we are not sure where we're actually standing. So
thank you. Sabin, 15-second magic stick question.
We need more rapid tests up to the community health workers. So everyone could do a test as simple as $1, probably, and maybe vaccinate those who are most at risk to get complication from this virus.
Merci. Caroline, 15 seconds.
With Musoka and the community engagement.
Good, thank you. Professeur Muyembe, Jean-Jacques, si vous aviez cette baguette.
Hey, Professor Muyembe, Jean-Jacques, if you had this magic stick and you could do one thing immediately, what would you do? I would test. And I would engage the community. Yes. Thank you very much.
I want to thank you all. We're coming to an end. I'm going to ask my colleague, Sam Ogiotti, who is one of our specialists at IDRC, to try to sum up your conversation. He has quite a task ahead of it. But before we go there, I want to personally thank you, each of you. I think that, I have an idea in my mind that I'm going to reconvene you in 6 months from now, and we're going to have the same conversation and see what has been going on in the field. You brought to this audience, the view from the field, and it's not very different than the view we have globally. You brought an Africa perspective on a situation that is affecting everyone and where you are playing your leadership role in harsh conditions. I want to thank all of your team, and thank you for your generosity and very busy schedule to sharing your story, as well as some of the things that work and some of the challenge that you are facing. Sam, I'm passing the baton to you, please. Up to you, and you have 3 minutes.
Thank you very much, John, for your excellent moderation of the panel today. And wow, what an excellent set of speakers and ideas. Close to an hour and a half or about. If we take a step back, we sought out to accomplish 2 things: to identify community-based responses, to discuss lessons learned from this pandemic and previous outbreaks, and then to identify gaps and opportunities for strengthening our disease preparedness on the continent. Have we achieved this? My answer, I believe, is a resounding yes. And here are a few important lessons that I have taken away. In terms of the overall status of COVID, cases are surging, and there are concerns that there might be a spike, especially as we go into the festive season. Testing rates are still relatively low. So the current figures that we've heard earlier today might be masking what Dr. Fala called the tip of the iceberg. And so that is a cause for concern and an admonition that we should not rest on our laurels. In terms of community responses and innovations, we've seen how crucial previous experience with disease outbreaks has been in Liberia, in Uganda, and the DRC. Dr. Fala used the phrase, we've already done the hard work with Ebola. And I hear him, and I agree completely. But that doesn't mean, obviously, we should relax. We've learned about the vital role that existing community structures such as community health workers can play. And personally, I take offense when people say community health workers are the last mile. To me, in Africa and many parts of the developing world, they are actually the first mile. And for many people, they are the only mile. And so it's really good to see how we've activated our community health structures in the COVID response. But we also recognize some of the resource constraints that we have, and that has pushed some of us to implement innovative strategies, such as the pool testing strategy that we heard from Dr. Saba in Rwanda. And we've also heard how it has been crucial to make a deliberate effort at communicating at the grassroots level in order to reduce resistance. Now, going forward, now that there are promising vaccine candidates, what does the future hold for Africa? We heard a mixed picture. On one hand, there's vaccine hesitancy in some countries, but on the other hand, there's vaccine eagerness in others. But then there are also concerns about the levels of infrastructure needed for rolling out these vaccines, the cost of these patented vaccines, and the general pandemic fatigue. Africa is quite communal, and so we can't just wait for the vaccine because it will take a long time before it gets to us. So we need to continue implementing the basic strategies. So I think overall it's been a very, very good event. And I'm really looking forward to part 2 if Jean lives up to his promise of convening us again in 6 months. But overall, it's been a great session, and I really like to thank our speakers, Prof. Jean-Jacques Muyembe and his colleague, Jimmy Kapeshi, Prof. Jane Tusime, who I ambushed at the last minute. Thank you for making it. Dr. Sabin Zanzimana, Ms. Caroline Bindio, and Dr. Musoka Fala, you have been amazing. To Team IDRC, our host and president, Jean Lebel, you have been amazing as always. Our vice presidents, Dominique Charon and Julie Chauvis. Our Africa regional directors, Julie Crowley and Catherine Toure. My colleagues, Morgan, Yolande, Lancelot, Christopher, Hingman, Angela, Fraser, Trish, and Michelle. Our technical partners, Collaborate Video, you have been awesome. And to all the participants, thank you for joining us. Merci beaucoup, stay safe. And we hope to see you all at the next roundtable in this series, which I believe we shall be announcing in due course. So bye and happy holidays to everyone. Take care of yourselves. Thank you.
Thank you very much. Merci beaucoup.